and Dr. Al-Kindi is awarded American Board of Clinical Lipidology from the United States in 2016. She is a member of National Lipid Association and board member of Oman Society of Lipid and Atherosclerosis. She is working as a chemical pathologist, senior consultant, and at Royal Hospital in Muscat in Oman. We welcome Dr. Manal to give her lecture. Dr. Manal.
السلام عليكم. شكرا دكتور خالد for the kind invitation. هل الصوت واضح؟
واضح دكتور تفضل.
ممكن نحط السلايد لو سمحتوا. I would like to thank the Saudi Society of Clinical Chemistry for the kind invitation. It's always an honor and pleasure to be part of this society. Although I'm going to talk about CA99, is it a reliable marker or not? It seems easy, but believe it or not, there's too many slides. So I'll keep you busy, so please be tuned. Just wait for the slides. There's too many cases in the slides, so please, I know that it's close in the dinner time, but please be with me and be tuned. IT people لو سمحتوا انتظر البرزنتيشن. I hope they are not counting this.
Of clinical pathology at the Pathology and Laboratory Medicine Institute of Cleveland Clinic, Abu Dhabi, in United Arab Emirates. She graduated as a medical doctor from Faculty of Medicine, Ain Shams University in Cairo. And Dr. Abdul Wal, his previous employment was at British Columbia Children and Women's Hospital in Vancouver in Canada. And she also has obtained a master's degree in health care administration from Zayed University in the United Arab Emirates. We'd welcome Dr. Layla to give her lecture. And sorry for Dr. Manal
for the problem in the technology, always happen. تفضل دكتورة ليلى your lecture.
Assalamu alaikum, Professor Khaled. Thank you very much. I'm so sorry for Dr. Manal, and I hope they can hopefully fix this. I'm looking forward to listen to her talk and the interesting cases, inshallah. I also like to thank Dr. Samia and the Saudi Society for Clinical Chemistry for their kind invitation to be with you tonight. Virtually. I would have loved very much to see you all truly, but this is a great initiative in very challenging times. So today I'm going to talk to you about the recent advances in the molecular diagnosis of breast cancer. And I have four main objectives. We'll talk a little bit about the value of genetic testing in hereditary breast cancer. We'll discuss the clinical indication for screening for familial breast cancers, and then understand the role of gene expression profiling analysis in breast cancer, and list the advances in molecular testing, again, in advanced breast cancer. Breast cancer is the second most diagnosed malignancy, right after lung cancer, and it is the leading cause of cancer death in women. I'm sure if I was with you virtually and if I asked the audience to raise their hands if they know of a close family member or a close friend or relative or a colleague who suffered from breast cancer, I'm sure that I will get lots of hands coming out. It is truly a common cancer in women, and it affects about 1 in 10 females, the lifelong risk. The advances in breast cancer management over the last couple of decades, actually, it really witnessed huge advancements. And it is mainly because of multifaceted interactions of several advancements, really. But certainly genomics and genetic testing, I would refer also earlier to Professor Graham's talk earlier today about the era of omics in general, and how this really fast-tracked a lot of development in the medical field. Definitely chemotherapy, hormonal therapy, targeted therapy, immunotherapy, the advancements in surgical intervention, and also in imaging. All of these have brought about a huge advancement now in our understanding and treatment of patients with breast cancer. And I know that this is mainly a discipline for our anatomic pathology colleagues, but I think now the borders are getting a bit into the clinical pathology, especially with the genomics and genetics. The technological advancements mainly because we have very good tools now for better understanding of genomics. Microarrays, gene expression profiling, transcriptome sequencing, next generation sequencing. These are all very powerful tools that are available in our labs now, in our clinical labs. And they are no doubt helped a great deal for us to understand better about the disease. Of course, the genome-wide association studies looking at various diseases and mutations and variations in a particular disease, the study of epigenetics and the regulation and expression of various gene activities. So let's talk a little bit about the genetics of breast cancer. And I'll start with the hereditary breast cancer. So basically, hereditary breast cancer constitute a very small fraction of breast cancers. It's about 5 to 10% of breast cancers. So 90% of breast cancers are not hereditary in nature, but about 5 to 10% are. And there are certain germline mutations, and by germline mutations, I mean mutations that one inherits from their parents, basically, that are very significant and put the individual at risk for development of breast cancer. Now, these genetic mutations are classified into by two main features. The first one is the penetrance, which is the proportion of carriers who actually develop the disease. And the second one is the relative risk, which is the measure of the risk of developing breast cancer as compared to the general population. So there are those mutations here which have high penetrance, really, with a relative risk greater than 10%. And these, of course, include the infamous BRCA1 and BRCA2, which we're all very familiar with, but also other genetic mutations in these genes, the TP53, the PTEN, and STK11, CDH1, all these as well are as strong as BRCA1 and BRCA2, and we'll talk about that in a minute. And then there is another category, which is medium to high penetrance genes. So again, mutations in these genes could also lead to increased risk of breast cancer, hereditary breast cancer. And then the moderate ones with a relative risk of 2 to 5%. And then the low penetrance genes, which has a relative risk of about 1 to 2%. So the high penetrance genes, I'll talk about them, the BRCA1 and 2, for example, they are associated with the hereditary breast and ovarian cancer. I think this is, as I said, perhaps the most studied and the most known mutations in these genes that predispose individuals to the risk of breast as well as ovarian cancer. Inheritance is autosomal dominant, and you can inherit it actually from your father or from your mother. And the breast cancer risk can be about 57 to 65% by the age of 70 years in individuals with various mutations, obviously, in these genes. And maybe it's a little less in BRCA2, but certainly very, very high, as well as the risk for developing ovarian cancer as well. STK11, again, is associated with another genetic syndrome as well. And it also is autosomal dominant inheritance, and it carries a risk, mutations in that gene carries a risk of 30 to 54%, again, of developing breast cancer, as well as an insignificant risk of developing ovarian cancers. The PTEN gene also, again, is another one associated with Coleman syndrome. Again, it's autosomal dominant. And this is why, again, it predisposes people with mutations in this gene, again, to very high risk of developing breast cancer later on. TP53, the Leifomeri syndrome, CDH1, and the PLAB2 and the BR1P1 mutations as well. So this is the high penetrance ones, and then these ones are the moderate to medium, but they are also attracting a lot of attention recently. But again, mutations in the ATM gene associated with ataxia-telangiectasia. Now this is an autosomal recessive, but it also carries a significant risk for developing breast cancer. CHEK2 mutation. This is not, this particular gene is not associated with any hereditary syndrome. However, mutations in that gene are still associated with high risk for developing breast cancer. And then NF1, NBN, and then all the Lynch syndrome, basically the mutations in these genes would lead to either breast or ovarian cancer risk. So the question then is how do we assess women who are or who could potentially be at risk for these familiar or hereditary breast cancer, and what tests should we apply? So the National Comprehensive Cancer Network, or NCCN, published very great guidelines actually for the management of breast cancer, and particularly for hereditary breast cancers. And the criteria in the guidelines is basically any individual at any age with a known mutation, either pathologic variant or likely pathologic variant, found on research or tumor testing. Or an individual at any age with breast cancer diagnosed meeting any of the following criteria. So diagnosed at an age less than 50, with triple negative tumors. So these are tumors that are estrogen receptor, progesterone receptor, and HER2 negative at the age less than 60, or had 2 breast cancer primaries, either in the same breast or in the 2 breasts. Or a breast cancer diagnosis at any age with 1 close blood relative with breast cancer less than 50 years, invasive ovarian cancer, male breast cancer, high-grade or metastatic prostate cancer or pancreatic cancer. And then also, I think, breast cancer diagnosed at any age with more than 2 close blood relatives with breast cancer at any age. And it goes on, and just, the last couple of indications here are individuals who do not meet the previous criteria, but were diagnosed with breast cancer at the age of less than 45 years. And unfortunately, most of the women in our part of the world actually are diagnosed with breast cancer early on in life, which is an alarming phenomenon as well. Or with ovarian cancer, again, history of male breast cancer, metastatic prostate cancer, pancreatic cancer. So you're getting the drift. Basically, they are looking at any indications of or any suggestions to suggest basically any of these familial hereditary cancer syndromes that I talked about before. So they are looking at any particular manifestations in the family with people with such syndromes. So then the genetic risk assessment actually is quite a comprehensive one, and it requires a multidisciplinary approach, but certainly clinical geneticists is at the heart of this, and a very experienced clinician, because these clinicians really need to take very detailed family history, do a focused physical exam, looking for certain clues that could tell them whether they're dealing with these hereditary syndromes or not, and have a very detailed medical and surgical history for the family as well, with a history of pancreatic cancers, prostate cancers, other breast cancers, and so on and so forth. And after all these are fulfilled and patient needs and concerns are addressed, then the decision then would be whether to do a focus testing. So, for example, if it is clear that this is a BRCA-related sort of inheritance, then it will just be focus testing on these BRCA genes only. For example, a Lufamary syndrome as well, which has certain phenotypic feature and familial clustering phenotypes as well. Then you can just do a single focus testing on targeting this particular condition. Otherwise, then the advice is to go for the multi-gene testing. If you cannot pinpoint one particular one of these hereditary syndromes that I talked about earlier. With the multi-gene testing, you have to be aware that there are different panels available. There is the 11 gene panel, the 14 gene panel, the 23 gene panel, etc. They're mostly NGS based and next generation sequencing based assays, and they are commercially available. But you have to be aware of the lab that you're using, and you have to choose the right lab. This is very, very important for your patient, obviously. And again, if you haven't invested in having a genetic counselor working with you in the laboratory, I think it's about time to do that, and it's the best investment ever, because these sort of professionals are very, very much needed in clinical laboratories nowadays. They help in selecting these labs, they help in guiding for testing for these disorders for physicians. They also help the interpretation of the results as well. Great people to have and in the lab, in the clinical laboratory environment, really. For sure, you have to make sure that the panel should include the high-risk genes that we talked about, the ones with the high penetration. So all these, at minimum, should be in the panel, plus perhaps some of the intermediate genes. And this is now the recommendation. And now you have to also bear in mind that there is an increased likelihood of finding variances of unknown significance, or the VOSs. And because of that, really it should be offered again in the presence of a genetic expert for the pre as well as the post-test counseling. So the patient who is going to have this sort of test have to have a very detailed pre-testing counseling on the ramification of this test and what it means and what is she going to do with the results, etc., as well as post-test counseling. What is the meaning of this result and what does it mean in terms of follow-up and treatment later on. I also want to highlight that there is now a new drug available, or classes of drugs available, which is the PA-RP inhibitors, or the polyadenosine diphosphate ribose polymerase inhibitors. And these are very effective now in patients with the BRCA1 and BRCA2 pathogenic variants or likely pathogenic variant carriers. And not only that, but I will also we'll be talking about this in patients with advanced breast cancers as well, because they are also as effective in patients with advanced breast cancer who have a somatic mutations that develop later on, not a germline mutation, but just an aberration that happens in their cancer itself. And they also respond very well to these PARP inhibitors. So then the role then of genetic testing for patients who are likely to be having familial cancers is not only because of risk assessment and also guiding the treatment, but there are also clear indications here to find various potential pharmaceutical interventions as well, or therapeutic intervention for them. We'll shift gear quickly then to talk about the molecular typing, and I'm going to talk about two very popular tests here. So the first one is called the intrinsic typing, which is the gene expression either by microarray studies or by, you can also do by RT-PCR on the breast cancer tissue themselves. So then this is looking at the breast cancer tissue itself. And basically, they look at various genes, the hormone receptor-related genes, the HER2-related genes, and the proliferation genes. And by looking at the expression of these genes, they can actually classify these tumors that perhaps look morphologically the same into 5 different distinct types with distinct clinical behavior and distinct treatment options as well. The luminal A, which constitute about 40 to 50% of these tumors, and we'll talk about the features of that. Luminal B, HER2 negative, luminal B, HER2 positive, and then the HER2 driven or positive non-luminal types, and then the triple negative or the basal or ductal type. So the luminal A is estrogen receptor positive, and could be progesterone receptor positive or negative, and the A is HER2 negative, and we'll talk about that later on. But it really, this type has the best prognosis, and we'll talk about the treatment options for this. Luminal B then is different than A by having excessive expression of HER2, but this is also beneficial because it guides the treatment of patients with this particular type with the use of HER2 inhibitors. And then you have another type of luminal B, which is HER2 negative, but ER positive as well, and have high expression of the Ki67, which is a proliferation marker. Now the HER2-driven non-luminal type is estrogen receptor negative, progesterone receptor negative, but it has a lot of HER2 expression. And the basal-like, unfortunately, this is what we call the triple negative breast cancers, and these are ER negative, PR negative, HER2 negative, and they express basal keratin. These ones, unfortunately, have the worst prognosis. So this is how it works. I actually very fancy slide, but as I mentioned, it looks as the various the proliferation markers, the HER2 markers, the estrogen receptor expression markers, and then it classifies those types. You can equally get that also by doing immunohistochemistry and FISH studies on this tumor. And people argue whether you should do the fancy microarray analysis or the FISH and ISH and immunohistochemistry. As long as you get to do these tests, it's now really a standard of care and very, very important. And as I mentioned, the reason being is it guides therapy. Again, back to the earlier talk by Professor Graham, the value added here of pathology and laboratory medicine is that we're really getting far way behind the boundaries of just diagnosis and diagnosing conditions. We are also in the midst of guiding treatment as well with the companion diagnostics and so on, as he elaborated earlier. So again, all these are various treatment options depending on the intrinsic type of that tumor, and the oncologist will then decide. Then I like to also spend a little bit of time talking about the tumor gene expression profiling, because this is another area which have witnessed a lot of development recently in terms of treatment and outcomes. So this is again looking at RNA expression of many genes, the same idea: proliferation genes, invasion genes, the HER2, ER, the estrogen receptors, and then some reference genes and some other genes as well. And you probably heard of the infamous, the 21 gene assay, the Oncotype DX, or the 70 gene assay, the MammaPrint, and many others. And they all have the same basically principal idea. And then basically you do all these combinations of RNA expressions, genes, you do a gene expression profiling on these tumors, and then you get what is called as a recurrence score, which is very important. So this is a very famous study, the Taylor-X study. There is also the MIND-ACT study or MIND-ACT trial, which looked at the MammaPrint, same idea. And what the study showed is, by doing this Oncotype DX and looking at the recurrence score, they could actually classify patients with a recurrence score of less than 10. These patients only were given hormonal therapy only. And then there are patients with a recurrence score of more than 25. They were given hormonal treatment plus chemotherapy. Now they had a middle group, and these are patients with a recurrence score of between 11 to 25. And these were randomized into either hormones plus chemotherapy or hormonal therapy alone. And this study was very interesting because basically it showed that patients with a recurrence score between 11 and 15 did not benefit from the addition of chemotherapy. So hormonal treatment was all what these patients require. Not only that, but patients less than 50 with a recurrence score in the 15 to 16, so basically in this group, but with a recurrence score of 15 to 16, chemotherapy was associated with improved survival. So in the younger patients, there has been some improvement if they were between 16 to 15. Women with a low recurrence score of less than 11 had excellent outcome, again, without chemotherapy. So including women with node-positive tumors. So these, again, revolutionized the way people look at breast cancer treatment and management. And it's, again, now is becoming a standard of care that, your oncologists, your surgeons will be asking about. But this is, for example, the sample report of how these things will look like. And for example, if you have a recurrence score of 5, that says that basically your 10-year risk for developing recurrence of this breast cancer is maybe 5%. While somebody, for example, with a recurrence score of, say, 40 would have a risk of about 35%, for example. So this transformed, as I mentioned, the management of breast cancer, especially the estrogen-positive breast cancer, in which these sort of tests are indicated, because it really provided a realistic sense of prognosis and chemotherapeutic benefit or not. And it's a very objective method, and it's involving the patient in the decision. So really facilitated better decision-making between the physicians and the patients, and saves a considerable amount of patients from the agony of having to go through chemotherapy. In closing, I'll just perhaps talk very quickly about the molecular profiling of advanced breast cancers and the use of liquid biopsies or circulating tumor DNA. So the genomic profiling of advanced breast cancer is testing for somatic mutations that the tumor itself would develop as it progressed. And this can be either by either studying the tumor itself or by looking at the circulating tumor DNA, again using the sequencing techniques. So it's performed through hybrid capture-based sequencing on large panels of genetic variants or events that covers hundreds and hundreds of somatic genes that are known to be mutated, again, in cancer. And there are recent advancements in these, and mostly, again, related to, for example, the development of the ER or ASR1 associated mutations, because this would be associated with resistance to the aromatase inhibitor in ER-positive breast cancer. So you would need to change the management of these patients. Or the MAP kinase pathway as well. And again, there are certain treatment for these particular mutations. So this is again, all these mutations and the associated treatment that one could entertain for these patients. So it's again becoming a very, very important tool. I think I am almost done here. So well, just in conclusion, then I hope I impressed about you that molecular testing for genetic and genomic variation has now become an integral part of breast cancer. Familiar breast cancer cases should have a very thorough evaluation and testing. That basically the gene expression analysis have revolutionized the way we look and classify breast cancer patients and also treat them. And there are also recent advancements with circulating tumor cell DNA in the treatment of advanced breast cancer. Thank you very much for your attention.
Very much, Dr. Layla.
For excellent presentation. And now we'll move on to Dr. Manal. I hope this time, inshallah,